have long-term medical conditions or health behaviours that may increase the risk of complications from surgery. And an estimated 1.5 million patients in the UK over the age of 75 will be undergoing elective surgery by 2030. As well as the increasing demand for surgery, there's also this kind of pandemic of multimorbidity, and about 60% of 60-year-olds and 80% of 80-year-olds have 3 or more comorbidities. So our patients are getting older and more comorbid. There have been quite a few other drivers for setting up high-risk clinics. The NC Pod Knowing the Risk report, the 2015 Royal College of Anaesthetists vision document on perioperative care. In Scotland, we've had realistic medicine since 2018. And in fact, even the surgeons have got on board the high-risk general surgical patient raising the standard report by the Royal College of Surgeons from 2018. And all of these institutions have agreed on the following points. So high risk is defined as any patient or procedure with a greater than 5% chance of perioperative mortality. There are about 10 to 12% of surgical patients who are deemed to be within this high-risk group. And although they're a small percentage, 80% of deaths in hospital following a surgical procedure occur in this high-risk group. And hospital mortality in this high-risk group is about 10 to 15%. So the purpose of identifying these high-risk patients is really so that we can recognise them early and try and optimise their care. And all of these reports agree that better multidisciplinary care of high-risk patients is required. So these were the main drivers for us setting up. Well, what makes a patient high risk? Well, generally it's their comorbidities, and these are the independent risk factors for post-operative morbidity and mortality. So you can see here that liver cirrhosis, cardiac failure and cancer confer the highest mortalities. And interestingly, age itself isn't an independent risk factor for surgical complications. This very nice study from Rupert Pearce's group in UCL looked at 70,000 linked primary and secondary care records for all patients between, I think it was 2017 to 2019, undergoing elective and emergency surgery. And they looked at the healthcare records for these patients in the 2 years before and after major surgery, non-obstetric, non-cardiac. And what they found, well, 11.8%, so around 12% of patients were deemed high risk. High risk patients who survive the immediate perioperative period experience large and persistent increases in healthcare utilisation in the years after surgery. So the 90-day mortality in elective patients was around 0.4%. However, of the kind of 50,000 odd patients having elective surgery, 12% of them were considered high risk, and they had the largest increase in per patient days in hospital or receiving health care. So it increased from 37 days per patient year before surgery to 60.8 days after surgery. So they're actually receiving health care more after surgery rather than beforehand. And they also accounted for 80% of deaths within the 90 days of surgery. And we can see here also the cumulative rate of death in this patient group is higher and persists for a long time after surgery. What are patients dying of within the 90 days following surgery? Well, generally it's most commonly dementia, cancer and cardiac failure. So clearly there is a need to identify these high-risk patients in order to optimise their care and avoid unnecessary surgery. So if we think about the traditional preoperative pathway, a patient is referred for surgical opinion. They then undergo a series of diagnostic tests, staging. They're discussed at MDT. They'll return to a surgical clinic. They will be perhaps then given a date for surgery, and that's when the pre-assessment happens. And often that's only within the week or two before surgery. And at that point, that's when patients might be picked up as being high risk. So again, there's been a drive to try and re-engineer the preoperative pathway, because much can be done between the time when surgery is first contemplated and the procedure itself to engage people in decisions about their care, assess the needs and risks of individual patients, optimise the treatment of long-term conditions and support people with modifiable risk factors such as smoking, nutrition anemia and diabetes. So we should be attempting to stratify these patients much, much earlier in the pathway so that we can intervene earlier than 1 or 2 weeks beforehand. So I'll explain a little bit about what we actually do in the clinic. So we screen patients to identify those at risk. We perform functional assessment, risk prediction. We undergo shared decision-making and consent, which is patient-centred. We pre-optimise chronic health conditions. We have an opportunity, or we use the clinic visit as an opportunity for lifestyle modification. We consider prehabilitation, and we plan perioperative care, including post-op critical care. So screening to identify those at risk, we rely on the surgeons and quite often the CNS is picking up the patients who are high risk. And we spent quite a lot of time trying to educate them around what constitutes a patient being high risk. So as well as comorbidities, poor functional capacity is a very important component of risk assessment for major study. And this study, the MET study, compared doctors' preoperative clinical subjective assessment of patients' functional capacity with alternative markers of fitness. So the subjective assessment versus CPET, the Duke Activity Status Index score on a questionnaire, and then various biomarkers such as NT, proBNP, and highly specific CRP. And they looked at how these models worked in terms of predicting death or complications after major elective non-cardiac surgery. And what they found is that the Duke Activity Status Index questionnaire predicts postoperative cardiac events in a way that the VO2 measured at CPET doesn't. And that's probably because the DASI takes into account frailty, patient's muscle mass, muscle weakness, and sarcopenia. The DASI relationship isn't linear and it plateaus around 34, so that's a really useful thing for us because we can use that as a cutoff for screening. So a score of 34 is equivalent to almost 7 METs, so it's 6.95 METs, or a VO2 peak of 24. And that means that these patients, underneath that cutoff of 34 points, are at risk of myocardial injury, myocardial infarction, moderate to severe complications, and new disabilities. Now, CPET's always been seen as the gold standard, but we chose to use the Duke Activity Status Index as a screening tool. And that's really due to kind of practical problems with accessing CPET and also a lack of time on pathways. So in an upper GI cancer pathway where a patient's undergoing neoadjuvant therapy, we might have time for CPET, but within other cancer pathways there often isn't the time to send patients off to physiology to have that performed. So these are some of the functional tests that we perform once the patients have been referred. So once they've been screened and their DASI has been completed, then an electronic referral form is filled out, which we then vet. Once the patient comes to the clinic, these are some of the functional tests that we perform. So some of our patients will go for CPET. We perform something called the 6-minute walk test. Alternatives to that are the shuttle walk test, the timed up and go test. We also frailty score patients, perform cognitive assessment, and sometimes check their plasma biomarkers. So the reason that we use the 6-minute walk test as a surrogate for CPET is really because of access to CPET. When we set up the clinic, there was no funding, so we weren't going to be able to buy a CPET bike. And we also wanted to use the time for shared decision making rather than for performing a test. The 6-minute walk test does in fact have some advantages over CPET and all patients can perform it, so there's really no contraindications. We have people with walking aids, patients on home oxygen, patients with joint replacements, and they just carry on and do it. It's not necessarily been validated as a pre-op assessment tool. However, we have good local data on its correlation with both the Duke Activity Status Index and CPET, and we've identified cut-off values in our patients for 1-year survival and for likelihood of having surgery. So we find it very useful. I'm not going to talk too much about frailty because we have another talk on it, other than to define it as a syndrome related to the accumulation of age and disease-related deficits that results in vulnerability to adverse health outcomes. Frailty is not the same as patient being malnourished, so just because a patient's not been eating and drinking and looks a bit skinny doesn't mean that they're actually frail. And frailty results in patients being much less able to withstand even minor stresses. So they lose their resilience, and you can see here as demonstrated in the graph that even a relatively minor illness can cause a very significant dip in their function, which can take a long time to recover from, and from which they might not recover to their baseline level of function. And again, this was a really nice study from Dan McIsaac's group on the effects of frailty in patients having surgery. And interestingly, they have a more marked effect after minor surgery, such as a hernia repair. Frail patients do recover from major surgery, but it does take them a very long time. We also assess patients' cognitive function using the abbreviated mental test. A score less than 4 is abnormal and it should prompt further cognitive screening. We also have to bear in mind the high levels of social deprivation in Glasgow, a low educational level, low literacy level here. And many of our patients don't actually have the intellectual ability to deal with the complex decision making being asked of them. So we do have to bear that in mind when we're having these conversations. So this is what our clinic population looks like. So this is demographic data from about 5 years of audit of 715 patients. So you can see here our patients do tend to be older, mainly equal male and female. We see patients from all specialties, so upper and lower GI, as well as gynae, sarcoma, breast. We're a tertiary referral centre for lots of surgery. The majority of our patients have cancer, but 40% of the patients that are referred to us have benign disease. Our patients are largely overweight. The median 6-minute walk test is about 78% of the predicted distance, and their median DASI score is below that cutoff. So we are clearly having the right patients being referred to our clinic. You can see that about 2/3 of our patients are either frail or pre-frail with low grip strengths as well. So that's what our patient population looks like. So I'll move on just to briefly talk about risk prediction. We mainly use NSQIP, which is, for those that don't know, a US-based surgical database. It's not perfect, but it does produce this kind of useful graph with a patient's relative risk, which is probably as individualised as we can make it. And it also provides good functional outcomes, which often are what's much more important to the patient. So useful information on whether or not it's predicted that they'll go back to their kind of pre-morbid level of function. We can also use the SORT risk assessment tool, which is available in an app. Neither of these scoring tools take into account frailty, and neither are ideal, but they do provide a good basis for discussion of risk with the patients. So after we have the information from the functional assessment, we then go on to our shared decision making. So shared decision making is a process whereby patients and clinicians work together to make evidence-based decisions centred on patient values and preferences. It involves explaining all options to the patient, including not doing anything, and then supporting them to make a decision that's right for them. So since the Montgomery versus Lanarkshire Health Board ruling, there's been a fundamental change in the ethics of how healthcare professionals now gain consent in the UK. And we're now being encouraged to discuss material risks with active participation by patients in deciding the best course going forward. And there's lots of evidence for shared decision making in patients. They become more effectively involved in making, so when they're effectively involved in making decisions about their care, they have fewer regrets about their treatment. They have better reported communication with their healthcare professionals. They have improved knowledge of their condition and treatment options. They have better adherence to the selected treatment, and they have an overall better experience with improved satisfaction. There's also less surgical regret and less people being sued, so it's all good. The aim of shared decision making is to provide information to ensure that individuals are not making decisions when they're insufficiently informed about key issues, and to support patients to deliberate their options by exploring their expectations and their reactions to information. So sometimes it's just about questioning what their expectation is of surgery and really working out if that's realistic or not. Some patients sometimes feel a little bit surprised or unsettled when they're offered a role in decision making. And if all the responsibility for decision making is transferred to patients, then they can feel abandoned, and some patients may be wary about participating. So often our patients don't make a decision on the day. They're encouraged to go away and take some time to process the new information that they might have been given at the clinic. They're encouraged to go away and speak to their family, perhaps to their oncologist or to their GP. They'll often then return for a surgical outpatient appointment and make a final decision at that point. And we find that 50% of the patients that we see go on to have surgery, 50% do not. That's either because the patient decides not to go ahead, the surgeon decides then not to offer surgery to the patients in light of the increased risk that's been perceived or been assessed, or because of disease progression. You can use a framework to support the process of making decisions, and this is one that's been developed by Choosing Wisely UK that have a very useful website. It helps support conversations where decisions need to be made, both in preparation for an appointment and during the appointment. And we use the principles of BRAN, benefits, risks, alternatives, and doing nothing. And that can be used by the patient to help them prepare for the consultation as well. They've got this useful bit of paper that the patient can fill out with questions that they want to ask during the consultation, so that they can already come prepared for the consultation. You've already kind of set the idea of this is going to be a two-way discussion. This isn't going to be about me telling you what you're going to do. So as part of the shared decision making, we also introduce the concept of anticipatory care planning, and we also discuss post-op critical care, ceiling of care, and treatment escalation plans, and we often involve our critical care colleagues in these discussions as well. We also discuss things with the patients such as power of attorney. Often when the patients come, they maybe know it's something they should have done, but again, this is a good moment for them to really start thinking about it and start discussing with their family what their wishes are. So we also pre-optimise chronic health conditions, which actually for us as anaesthetists is the easy part. We'll send patients for pulmonary rehab if they have COPD, we'll treat anemia, we'll try and get better control of diabetes, we'll make sure that we're protecting their renal function, we'll optimise their anti-anginal and anticoagulant meds, we'll perform polypharmacy reviews, and we have a perioperative pharmacy service which has been set up as part of the clinic, which works very well. And we can also refer patients for comprehensive geriatric assessment. So we can refer any cancer patient over the age of 65 to the Cancer and Older People Service at the Beatson Hospital, which is a large cancer hospital in Glasgow. So we don't have a comprehensive geriatric assessment for all our patients, only for the cancer patients over 65. So comprehensive geriatric assessment, as you can see in the slide, is an interdisciplinary multidimensional process. It looks at the domains of physical, medical problems, mental health conditions, function and social circumstances. It leads to the generation of problem lists with goal-driven interventions, and it provides and coordinates an integrated plan for treatment, rehabilitation, support and long-term care. What's the impact of comprehensive geriatric assessment? Well, in cancer patients, they're more likely to complete their cancer treatment, they're less likely to need treatment modifications, and they're less likely to suffer from grade 3 toxicity. So there's good evidence that it works. What do older people want? Well, 50% of older adults consider other outcomes more important than survival. 2/3 of older adults consider their current quality of life more important than their future quality of life. 60% of older adults would rather live a shortened life than not be able to look after themselves. And 83% thought that it was more important to maintain their thinking ability than to live longer. So it's important to ask our older people what they want. And in the words of Jay-Z, quite often there are a lot of other problems going on with these older people, and they can live with their cancer with best supportive care without surgical intervention at sometimes. I'm not going to talk too much about prehabilitation because we're going to have an excellent talk about that coming up. Other than to define it, it's the process of enhancing functional capacity of the individual to enable the patient to withstand the incoming surgical stressor. It comprises 3 parts, so physical activity, nutrition, psychological preparation and support, and Myra's going to talk about that later. So just to finish off, it's very much about teamwork. We have, over the years, evaluated our service at every stage. We've expanded, we've evolved over the years. And as a result of our success, we're now embedded in the service with lots of input into various MDTs. We work very closely with our surgeons, our cancer nurse specialists. We've recently just employed a prehab assistant practitioner, which is one of the first roles in the country. So I'll finish off there, thanking the team, and happy to be contacted for any information. Thank you.
Thank you, Dr. McKinley. We'll keep for the questions at the end. So I'd like to introduce Dr. Mon, consultant anaesthetist at University College London, who's going to talk about embedding patient involvement in perioperative care, establishing an award-winning network for bariatric team training.
Thank you for inviting me to speak today. I'm going to talk about our MDT simulation course and how we embedded patient involvement in perioperative care training. So our course is called Bariatric Emergency Simulation Training, BEST, and it's for multidisciplinary participants and run by multidisciplinary faculty. We had expert patients all the way from the design of the course to the delivery of the course on the day. And we were the winners for the Patient's Voice category at the HSJ Patient Safety Congress this year. So why do we do it? Inception of the course came from the current problem of knowledge and experience gap among junior surgical and anesthetic residents and the communication difficulties that they may have when dealing with patients living with obesity. We all know that bariatric surgery usually takes place in specialist dedicated center, and the perioperative care is given by consultant surgeons and consultant anesthetists. But when these patients come back for emergency, and when they present themselves to emergency department, the junior doctors, junior residents will be the one managing them. So a lack of familiarity with the bariatric surgery and potential complication can lead to delays and failure to recognize and manage the complication. And both surgeons and anesthetists have silo training approaches. My anesthetic residents would may be away, during theatre, and they may be getting ready for the next case, or they may be seeing the next case, so they may not see the whole perioperative journey. It's the same for the surgeons as well, because surgical residents are usually present during the operation, so they may not be aware about the potential challenges and complications that anesthetists can have at the induction and emergence of anesthesia. And finally, it's the communication challenges. And all healthcare professionals have conscious and unconscious bias when dealing with patients living with obesity. And stigma surrounding obesity is very much prevalent, and it can lead to poor communication, failure to provide essential information about perioperative risk, and leading to breakdown in the doctor-patient relationship. And patient voice is often missing, especially in our postgraduate medical education. So objectives of our course were to understand the management of bariatric surgical emergencies, to recognize the prevalence of weight stigma and its potential implications, and to develop effective communication strategies for discussing perioperative risk related to patients' weight. Patient involvement in medical education is not new, but traditionally they play a more passive role. We may ask the patient to help us with history taking, or providing, for example, assistance with clinical examinations. But we really should consider involving them as a more active participant, because the evidence for involving patients as educators is becoming more compelling. It fosters patient-centered care, it promotes interprofessional relationship, and encourages shared decision-making. When we decided that we would involve patients, we asked other simulation teams in London. None of them had any experience with getting patients involved in simulation days and scenarios. We also looked up literatures, and we found quite a few regarding patients' involvement in healthcare education. And this is one of the articles published in 2022 describing 12 tips for patients' involvement. It was a very useful article, but in the end, we just decided to go with tip 12, and we just did it. We had a very experienced MDT faculty. Margot Adamo was the surgical course director. Nadia Isaac, who is the advocate for patients living with obesity, was our former patient at UCLH, so she was our expert patient. We had some challenges of finding a realistic sim mannequin. There's none in the market, so we use adjuncts to make the sim mannequin more realistic. All clinical scenarios were based in emergency settings, and they were relevant for surgical, ICU, ED, anesthetic residents, and nursing staff. Scenarios follow through the patient's journey from pre-op presentation as an emergency presentation to ED, all the way to theatre and post-op complications. So on the day, we started with interactive lectures and workshops, followed by scenario, and there was an MDT debrief at the end of each scenario. So all the simulation scenarios and workshop highlighted key clinical and communication challenges in patients living with obesity and how we could tackle them. So for each scenario, we usually have one surgical ED resident, anesthetic resident, and a nursing staff. For example, for preoperative management, we had emergency residents and anesthetists preparing the patients for surgery, consenting about perioperative risks. For intra-op scenario, we have nurse, surgeon, and anaesthetist. For post-op complication, we involve the ICU residents and the surgical residents, and we concentrated on the transfer of critically unwell patient across the hospital to CT scan and to ICU. At the end of each scenario, clinical aspects were debriefed by the consultant surgeons and consultant anaesthetists. Non-technical skills were debriefed by simulation faculty, and then we gave patients 5 minutes to talk about her experience and how she felt during the scenario. And having Nadia there really provided contextual information and how the effect of illness and emergency presentation had on the patient as a whole. The course feedback was very positive. As you can see here, 87.5% of attendees were confident in resuscitation of acutely unwell bariatric patients after our course. This increased from 28.6%. When you look at all the skills on the right-hand side, such as managing patients in remote sites, such as IR, CT scan, endoscopy, and assessing surgical and anesthetics risk, the confidence level improved significantly from pre-course to post-course. Regarding communication skills, our participants felt that hearing the patient's voice was such a useful experience. It reminded them of the importance of using respectful and non-judgmental language in dealing with patients. It took me 1.5 years to set up this course, and there were a lot of practical administrative challenges, mainly to get the simulation center availability and funding and stakeholder buy-in, and trying to find the time for MDT and also for the simulation center at the same time. We got the patient experience team at UCLH involved, but they have very little experience in getting the patients involved in simulation training days, but we worked together collaboratively to come up with some guidance for the patient. So some consideration when involving the patients, that you really need to have a structure elements. Patients need to be informed about what the day would look like, what the scenarios are going to be, and potential outcomes of the scenario. And for debrief, you need to give some structures to the patient as well. The most important thing I felt is the psychological safety. So we really need to make sure that patient is looked after during the course of the day. And I assigned one of the faculty members to be the person to go to for the patients if she had any concern. We were lucky that we had the broad MDT participations for the courses that we run. So the MDT participants, surgeons, anaesthetists, ED residents, they actually performed their actual roles during the scenario. And educationalists from the simulation center, they really ensure the structure and meaningful debriefs for our candidates. So what would we particularly like you to take from our learning? And there is growing recognition for the value of patients and values that patients bring as educator. So we really need to start moving away from asking the patient to involve as a passive participant to more active contributors in the postgrad medical education. Having the MDT and the patients really provides a meaningful training, and it enriched the training experience. And this should be a blueprint for future training for anesthetic residents and surgical residents, because having the MDT and having the patient's involvement in a high fidelity simulation scenario really enhances team working and patient-centered care. And thank you. The next course is going to be on the 7th of January, obviously 2026. And this is a link for the course to register interest. Please feel free to share with anybody who may be interested in the course. I really welcome any collaboration or any suggestion for the course as well. Thank you.
Thanks very much, Wynne. Next to the stage, I'd like to welcome Mark Johnson, who's a consultant geriatrician from Liverpool, but also has a role both within the British Geriatric Society and more locally about setting up teams for the care of the older patient population.
Well, thank you very much for inviting me, and thank you to all of you for attending today as well. And I don't have any bribes as of yet, but I'm open to offers. But as you've just heard, I've got a few different roles. And you've heard the environment in which we all work within and that we all experience quite well described by our previous speakers. And I don't need to sort of drill it into you guys that what we're being asked to deal with is getting more complex. We've got to deal with the concept of multimorbidity, and people have now got more advanced diseases than what we've ever seen before. But the saddening indictment that always really makes me pause to reflect is a seventh of our patients are regretting the treatments we're enduring, but asking them to endure. And a lot of that comes down to shared decision making and the conversations that we have. And what I want to talk to you about is the next stage of our evolution when it comes to perioperative medicine. And you've heard some of the admirable feats that our anaesthetic colleagues have been doing to support you guys. And we're effectively the new kids on the block as medics coming into your environment. And we can use this as a way to reset the relationship and actually utilise our skill sets to its most benefit. But we're in uncharted territory here. We are witnessing the biggest challenges that we have ever seen, and our current models are unsustainable. They are completely unsustainable. Every ICB in the territory is in debt, and we're about to go bankrupt. And why is that? Older people are having to rely on health services disproportionately, sadly so. And for the first time in our history, not only has ageing gone up, people are living longer with increased levels of disability and other ill health, and that's where the challenge lies. And each area has its own heat map, which you may or may not be familiar with. And we're very good in Liverpool at diagnosing chlamydia, but that's not a challenge. And every area should have its own strategy. And look, it doesn't say reduce the amount of cancer, make people live longer. How do we help people live the lives that they want to live? And that's what you guys do and are actively involved in. And why are we seeing these challenges? Well, the biology of ageing and the biology of frailty itself is a fascinating one. The body does change. And, in this country, we define older as over 65, but it's fair to say that once you exceed your 20s, this period of deterioration, sadly, begins. And in its simplest definition when it comes to frailty is we've got a loss of homeostasis in an older person. And all our evidence base, all our science is geared up for that textbook perfect patient. And this is frailty, that cycle of decline, the challenge that our patients have to endure. And at the heart of it on the right, it's sarcopenia that we're most worried about. And the holy grail in medicine we're yet to discover is how do you reverse or break that cycle? And, this paints a picture of what we see with our patients, that once they're caught in this, things get worse and worse and compound. And we have extra patient factors that feed into this. But obviously with reforms in preventative care, and we're going to hear about prehabilitation and other interventions that are really important, that's how we can slow this rate of decline. And in some cases, reverse some aspects of decline. And this is what the patient experiences from a functional point of view. It is important we get our definitions correct. Frailty is not the same as multimorbidity, nor is it the same as syndromic conditions. But as you get older, you're more likely to have a combination of all of the above. The older you are, the more medical conditions you have, but also you're more susceptible to what are called the geriatric giants. And every frailty unit in the United Kingdom right now actively screens older people for this. But here's where we've let you down. This doesn't happen in surgery as routine, and it should. Because how many times have you had that patient where you've done a fantastic job and something's come undone because of one of these things, an area in which you don't have the skill set, and we need to consider that as to how we support you with this. We've had every single national policy you can think of that's extolled the virtues of what I've said that we need to change, and this goes back over a decade. But we have to ask ourselves, why are we still not there? And we've been given the toolkit as to what the ideal perioperative pathway for the older person should be. And I'll summarise it to you. Assess for frailty at the earliest opportunity and intervene. As simple as that. And utilising frailty assessment is the most radical thing you can do for your patients, which I'll come on to in more detail, which will do that for you. Now, we're very lucky that this year in the UK, SNAP3 has been published, which was a large observational trial which was performed by multiple agencies that looked at every single patient in a surgical bed in the UK. Over 200 trusts, thousands of patients were included. And it shows you what you expect when you're doing your ward rounds. A fifth of all surgical patients are frail. 2/3 are multimorbid. And in some regards, there's some overlap, and in others, there are not. But here's what gets more interesting. As you know, outcomes start to deteriorate. But here's what's interesting. Multimorbidity is not as strongly correlated with poor outcomes as frailty is. And our traditional models have focused more on those individual medical conditions. And actually, this is now proving the point that actually frailty is one of the biggest risk factors that's going to determine what outcome your patient is going to have. Now, despite all this evidence, and I could spend a whole hour speaking to you about the evidence base, and it's irrefutable what the science says. What does local and your societies talk about when it comes about frailty? Well, it recognises that these are diseases and conditions of old age. Obviously, the benign upper GI subgroups are more younger in nature, but we've got acceptance that there's older patients at play. But sadly, still to this date, no comment on frailty. And that's something we'll come back to when it comes to what can we actually do about this. Because it explains a lot of your data, and I think you're missing a trick by not including this in your data sets. And also we must accept, and I work in Liverpool, social deprivation is a big determinant as well. And be under no illusion, patients have financial considerations when they make a decision. You may not know this, but if any person in the United Kingdom requires long-term care and they have assets over £25,000, they're paying for their care. So anyone that effectively owns a home, if they need a package of care or go into a care home, they're losing the house. After they die, perhaps, or even before. And when you talk to patients, money is on their mind, and we must be mindful of that as well when it comes to that holistic aspect. So we've set the scene, so let's talk about, well, what can we actually do and what do we do in Liverpool and what we developed, and by no means are we the finished article. We're very lucky that we've had a service for 10 years, and the rest of my colleagues are the stars and the service itself. And we're still scratching away at the surface, and what we've identified is that there's 3 key phases that you need to zoom in on when it comes to older person perioperative care. Making sure the decision making is robust, and we're supporting that. Optimising and looking at things that we can reverse and remediate, and then actually that peri-interventional care at the end. There's no one size fits all, and every trust is doing it differently. But sadly, we still have less than 30 trusts in the country that have dedicated POPs teams, and one of our missions with the BGS is how can we try and help support that and support you get what you deserve. Finally, these aren't just clinical services, and actually embedding yourself as a physician within your mortality, your audit, and your education programs as well pays dividends. So what do we do? It's the CGA that you've heard, this dark art, this magical wand, and in its simplest form, it's not really anything too clever. It's about not compartmentalising the problems and looking at the whole picture. And I, as a medic, have my role, but there's a whole team. And for those of you who are interested, find me for coffee or contact me later and I can explain the quote to you. But my field is one of lateral thinking and puzzle solving. And we can break apart all the different frailty interventions, and we have to critically assess each individual surgical pathway as to are we actually addressing this. And I won't dwell on this because our prehabilitation speaker will talk about this more. We in Liverpool, along with our preoperative lead, looked at what were the commonest reasons why surgery was getting cancelled and where were the easy wins and the low-hanging fruit with our patients. And this was the sort of screening assessment tool that's been developed in Liverpool. And again, this is a work in process. But obviously, we were delighted as a team that our anaesthetic and surgical colleagues agreed that frailty in of itself is important, and we like to offer this support. And I'll talk to you a little bit about what we do. The Montgomery report clearly articulated that it's not what we perceive as risk. Older people are not afraid of death. They are not afraid of death. What scares the life out of them is there from the MS quit. Discharged to a nursing home or a care home. Independence is key. And the sad thing is that most people deteriorate and die not directly because of the surgical pathology or the surgical procedure in of itself. They die of pneumonias, heart attacks, heart failures, things that are part of our arena. And they typically die a week or further after. And that's a problem as well, because when you list a patient that's high risk, they go to critical care, and it gives you that feeling of false reassurance, but they're not dying on critical care. It's after they go to the wards, and that's actually the safer relative period. Some conditions are preventable as well, and if you use delirium as an example, about 1/3 of all perioperative deliriums are preventable just from a medication review. And how we assess risk and identify risk is very traditional. We have a cardiovascular, cardiorespiratory approach to identifying risk, and it's unidimensional. And even when we do it, it doesn't really feed into that traditional MDT process. And it's interesting, when you correlate it in pancreatic subgroups, if you look at the top, it's very binary. When you look at PS doesn't really help you. You can tell when you look at the patient if they're fit or not. What actually interests us is, where's the grey zone? And when you look at introducing a CFS alongside PS, it gives you that delineation in that grey zone. And I divide older people into 3 subgroups. The really fit ones, let's crack on. We don't need a song and a dance. Let's just get this done. One group where this is clearly futile, or the interventions we're proposing are going to really destroy this patient. Or the third group, which is more intricate, where we need to lift the hood up, we need to really do some deeper delving here and do some interventions, and this person will get through. And I believe that's what the role of risk assessment is. What cohort does this patient go into? And then we push our infrastructure into that. At the moment, we have a blunderbuss approach where we throw everything at everyone. And I think there's a talk later about CPET, and that's a good example. Deciding who you're doing what to is the skill of an expert clinician. Once you go above a CFS of 4, that is the danger zone. Even a CFS of 4, most older people cannot tolerate 1 cycle of chemotherapy, and 4 is not bad at all. So what do we do, and what happens if you put one of your patients in front of a clinic with a person like me and a geriatrician? Well, the national evidence and our local evidence shows that we're going to be picking up new diagnoses that have never been considered. I saw a breast patient last week that I just diagnosed with Lewy body dementia, and if we hadn't done that, there would have been some catastrophic consequences post-operatively. We give lots of advice as part of the holistic management, reviewing the medications, mitigating against a whole host of further referrals. And in its simplest term, as a geriatrician, I'm a complexologist. So rather than you getting the heart doctor, the lung doctor, the kidney doctor, we're the teams that are able to understand that, well, if we do management plan A over here, this is the impact it's going to have on this other organ system here. So the evidence base is starting to show that that's the sort of the things that we deliver at the patient level. But not just that, operationally we're seeing improvements, and our first speaker highlighted that to you. And when it comes to decision making, all we have done is codified this. What does success look like to the patient, and what treatment that we're going to deliver? Can it survive the gauntlet of Bran? We're very good at B. We're very poor at R, A, and N. And I know all of you as surgical and perioperative colleagues do this in the cerebral environment, but it's also important that we articulate this. And this is something our Liverpool colleagues do really well, explaining to us as a geriatric medicine team, actually, this is the proposed treatment, and actually, this is why we're thinking this for benefits, risks, alternatives, etc. And it leads to better shared decision making. And when they come to us, this is a typical overview of all patients that get listed for surgery, who they're actually seeing. So obviously, a majority of people that pre-op nurses are seeing are actually relatively fit with no complications. A good proportion are sent to prehabilitation, and they're not being asked to see too many unfit people. You can read into that whether that's success or failure, because you could argue, should more not fit people be seeing prehab? Because maybe they could become fit, but read into that what you will. And once you get the medics involved and the anaesthetists involved, that's where angels fear to tread. And people could think I'm a miserable or a pessimistic sod when, a lot of the patients we're seeing, we're thinking, this really is not for you. But the national evidence is saying that when someone sees a geriatrician, an additional 15% will decide they do not want invasive intervention going forward, in addition to those that are not fit. So I want to give you an example. I accept and understand this is not an upper GI pathology, but this is to give you a window into the soul of a physician as to how we approach it and what we're thinking. So typical case, and you can replace DCIS of the breast with any pathology you want. 70-year-old lady, she's got a pseudo-early cancer, and surgeon wants to resect it under general anaesthesia, and here's the comorbidities that this patient is experiencing. And I get a referral saying, well, they're frail, see what you can do to help. And these are the comments I had from the surgeon and the anaesthetist. It's only a day case. She's fit for GA. This disease is causing us stress. There's nothing to optimise, but it's cancer. If there's another point that you take home for today, is that cancer is not just a physical illness, it's a psychiatric one, and it affects both the patient and also the clinicians alike. And it's very important we remember that. So what do I do when they come to me? So what does the patient want? I don't want to die. Very rare you meet someone who does. So what's the average life expectancy of a 70-year-old female? Remember, we've been trained in the art of prognostication as geriatricians and deal a lot with end of life. Well, if you look at ONS data and you pool everything together with accrual tables, she should get about 16 more years. So the next question is, well, if we leave this condition, how much is this going to shorten this patient's life for on average? Or you can do some maths workout when it becomes an invasive cancer, and if we leave it untreated, what's her survival going to be? But ultimately, in this case, it's fair to say her adjusted length of life, if we leave it as it is, would be 83. Okay? So then let's consider what happens with her comorbidities. Well, let's just think about obesity alone. What's her prognosis with obesity? 76. The whole system and infrastructure has become obsessed in a zealous way. Oh, my goodness me, she's got cancer. Must cut it out. But obesity is going to kill this patient long before cancer does. And the saddest indictment of this case was that phrase, there is nothing to optimise here. Last time I checked, we've got Mounjaro and other brands are available and other interventions that we can do to support people with obesity. But we've got to ask ourselves, why has the system allowed that to happen, where we'll just push dangerous things aside? Here's another one for you. Untreated severe aortic stenosis has worse outcomes than metastatic cancer. It's a terminal condition. So take medical pathology seriously and consider where our skill sets begin and end, and when you need a prognostician to be involved. And we're very good that when people are in the last 48 hours of their life, all of us are very good at that, and anything beyond is a challenge. The biggest mistake I see that colleagues make is they go straight to step 3. We can all get 5-year survival rates for whatever cancer, whatever condition you want, but go back. Would I be surprised if this person was dead in a year, half a year, 2 years? See when the answer changes, then go to step 2. What are the general indicators? Are they frail? What's the serum albumin? It's all there in the gold standards framework. Then add in step 3. And it's very common that, and again, people think we're really pessimistic because we come along saying, you do know this person's got about 2 years, 1 year, whatever it is. And it's because we've considered step 1 and step 2. Build this into your consultation and thought process. But also, we all must be humble as clinicians as well. You guys have amazing knowledge, I don't, and vice versa. And when you're trying to consider what the benefit of the treatment is, maybe consider these under concepts, not just the pathology at play or the one that we think is at play. There's medical legal sessions going on at the moment as well, and FOI requests to NHS are showing that suing the NHS about poor informed consent is increasing, and it's mainly amongst the surgical disciplines, and we anticipate this is going to increase and increase and increase. And when it comes to assessing risk, most of these causes are medical in nature, and we must consider that grey zone, the perioperative period, we've got to zoom out a little bit more. The patient was on a pre-existing destination, and then there's a new trajectory going afterwards. And that's what we then decided to do as a team after we've done the pre-op, that inpatient review in a proactive rather than reactive way. Because we learned that we were seeing these patients a year down the line. So now it's, well, how do we get to you guys even sooner and support you on the wards? And this is my operative field. Medicine is physiologically and pathologically complex. And the commonest things we're asked to deal with are all of the above. And this is another amended table which our first speaker showed and summarises the point as well. Most people will die later on, and they will die of other medical pathologies. And we've been quite lucky as well that one of the barometers, I think, of how effective a trust is at getting physicians to support surgeons is actually looking at NELA. Now, we don't exclusively do NELA, but the only reason that we're doing so well with NELA is because we've refined that model with how we support you guys, rather than referring, because how can I ask you to tell me, how do you know what you don't know? So I need to have mechanisms whereby if you contact me, we're responsive, but also we can identify things that we're trained to identify, and that's where the power of the specialist nurse comes in as well. And we've been really lucky, and we've really pushed this, and we're a national exemplar when it comes to NELA. 10th year report is on its way, but we anticipate good results. But the saddest indictment as well is, why is no one else following suit? If you want to transform and get these services in your trust, this is the way when I sum up. Not only is it good because it shows you a good graph, outcomes improve, and we're one of the only trusts in the country which has actually seen a reduction in length of stay, because actually when you include geriatricians, length of stay actually goes up. And Neil is going to do a deeper dive as to why in Liverpool we're seeing reductions in length of stay. Any trust that achieves NELA, you're looking at £200,000 extra best practice tariff. So that's the motivator when you go back to your trusts if you don't have geriatricians. Look at your NELA data, and that's how you can get the business cases and get that extra support put in. Money speaks. So we're coming up to what I think we need to do. I think you need to self-assess. I can't tell you your vision for the future, and I can't tell you what you want. But I would like to think we all share the same vision in improving all these outcomes that we have. I think we're at an exciting time with the paradigm change where the role of the physician in the pathway has begun, and I think that's where all our low-hanging fruit is. I accept all our technological advances are great, but I think including teams like ourselves are going to be equally, or if not more, transformative than those. We have to have an honest conversation about who makes decisions and who discusses decisions with patients at the right time, and we have to have a bespoke approach for each patient. Sometimes it'll be the surgeon, sometimes it'll be the anaesthetist, sometimes it'll be us. Are your processes sustainable? And I'll show you next slide why that's the case, and what's your vision. Let's incorporate what we do with the NHSC principles that have already been said. If you identify for frailty, it's the most important risk factor that you've got. That'll tell you you're high risk. Implement prehabilitative processes early on. Demand and expect from your organisations the admin support you require. We are clinicians at the end of the day. We're not project managers and we're not admin teams, but we need admin support so that your patients are being tracked and all these interventions are being coordinated. One thing I will still not understand to this day, and one reason why I would really struggle to be a surgeon, is I still to this day don't understand how operating theatre lists are managed. I don't know. The scraps of paper or the books, and it sounds like if anything happens to that book, it is the end of days. What I believe perioperative medicine needs to be like is, it's like if you get on a plane. We would not get on a plane unless someone made sure there's fuel on board and the wings are attached. But at the moment, we've got planes that are told they are lifting off at this day. I'm talking about TCIs, just to be clear. That plane is leaving at that time. Hold on a minute, mate. We've got no wings here. We've got no pilot. Let's go back to that safety culture which the airline industry uses. And actually, I think we shouldn't be issuing dates for patients. And we should have the fortitude to say, yeah, we know that NHS England are putting all these demands and targets on us, but we should not compromise quality or safety. At the end of the day, you're the ones that have to answer when it goes wrong. The chief exec isn't going to be taking the bullet for you in the majority of cases. You've got the toolkits that you need, and I think these give you all the QI and the research options that you need for cancer, for surgery, and operationally as well. Implement the frailty intervention tool. Reform processes. MDTs are too long, they're boring. They talk about disease, I don't know this, I don't know that, some little cystocyte or whatever the hell it is, I don't know. But discuss the patient, not the disease. And also, let's work on how we communicate. You know what it's like when you've got that complex patient, we're all emailing each other in a flurry. Again, I think we need to invest with how we discuss the lead-up of the patients. And also, we need to be political, and I'll talk about this in my next session as well, as let's increase the inclusivity, and particularly with you guys, and thank you for inviting us to talk to you today to show that you value our input. But again, the role of physicians and anaesthetics, along with not just surgery, perioperative care is not just about the surgeon or the scalpel. It's about the whole infrastructure around. And you guys need to consider this when it comes to policy and guidelines as well. And we're coming to the end, so don't worry. Let's be more bold. In the whole of NODCA, I could only find one comment on frailty, so let's praise it, but it talks about palliative chemotherapy. How about the next time someone authors this, let's have frailty assessment as core and align it with all these other policies that we've got. We all need to share a language. We all need to share that QI drive going forward. And I'll end on this. 80 years ago, the mother of geriatrics, and we have the pride in the United Kingdom of inventing geriatric medicine. This challenge still stands to this day, and it's always going to be a challenge we need to evolve towards. But we're really excited working with you guys going forward, and hopefully I've given you something that you can inspire you to go back to your trust and go back to your geriatricians and say, we want a piece of this. I'll tell you a secret. We've got egos as well that like to be managed. And if I was a physician in your trust, I think it would be lovely if a surgeon came up to you and said, we really need your help, guys. What can we do to help make this happen? We want to work with you. A&E and the community is a black hole. Elective care has been ignored for too long, in my opinion, because the chief execs and the trust, they only care about the front door. So I think it's now your turn to get the support you deserve. Obviously, there's always so many people to thank, and I have to mention the SNAP3 team and also Claire Swarbrick, who's one of the anaesthetic trainees who does a fantastic job. And I hope that's given you some food for thought, but thank you for listening to me.
Thank you, Dr. Johnson, for the great talk. I'd like to introduce Dr. Myra McAdam, consultant anaesthetist at Glasgow Royal Infirmary, talking to us about prehabilitation, why it should work, and how we do it. Thank you.
Thank you very much for the invitation to speak in the introduction. It's always slightly nerve-wracking being the last person when people have promised what you're going to talk about and I'm not going to talk about them. But I also realised I could solve your problem in 2 sentences. Eat enough protein, lift weights. And I also realised in Scotland's home of its only High Rocks event, get your tickets today, I really should have put a picture of the oldest High Rocks world champion in this slide. But anyway. So I'm a consultant anaesthetist at Glasgow Royal Infirmary. For the past 4 years, I've also been the West of Scotland Cancer Network Regional Clinical Lead for Prehabilitation. So you would think I would know all the answers. I don't. 10 minutes is a very short time to talk about prehab because you can dedicate a whole conference to this, and people do. But I'm going to do my best to stick to time, no promises. I'm going to skip over a bit of the science because you've had other talks about prehab. I'm essentially going to talk about what Sonia has already mentioned. Prehab is an intervention that will provide patients diagnosed with cancer a chance at improving their own treatment-specific outcomes, even if that treatment is best supportive care. Most of my focus is going to be in esophageal cancer, which is relatively more common than gastric cancer in the UK. And I'm only going to talk about prehab for cancer, although much of it is relatable to the benign disease. In Scotland, cancer mortality has been falling. It's dropped by about 11% since 2013, when it was last checked in 2022, but the number of deaths from cancer are still rising. Men are higher risk, and they have poorer survival overall. Some of that is maybe related to the fact that as you get older, men are more likely to be diagnosed with cancer. A little bit of the evidence for it, so I'm just going to talk about a couple of systematic reviews, neither of which have been able to do a meta-analysis because there's not enough evidence out there. And this is specifically looking at upper GI cancer. The first paper looks also including hepatobiliary cancer as well. The theory behind the benefit of prehab is that fitter patients have higher physiological reserve to withstand the stress caused by cancer treatments. Now, part of the problem that we have in prehab is that most of the evidence looks at surgery, but the vast majority of patients who have cancer have treatment other than surgery. Physical activity, if you look at it on its own, and that's where most of the research is, improves your immune function, specifically cells like your monocytes, your macrophages, your natural killer cells, the ones that are in charge of controlling cell growth. It reduces insulin and leptin, so part of the hormone cascade that encourages tumour growth and metastases. And it also reduces the hypoxic environment that tumours like to thrive in. One of the benefits of that has been looked at in systemic anti-cancer therapy is specifically looking at how you can improve the delivery of chemo to a solid tumour. If you exercise, you increase the blood flow, makes sense that chemo delivery improves as well. This paper looked at essentially whether prehab is good or bad. And we do know that prehab will reduce post-op complications. That's pretty well established in the research. When you specifically look at kind of upper GI cancers, there's about 15 times increased risk of a pulmonary complication with an upper abdominal incision compared to a lower abdominal incision. So it would make sense that prehab would reduce your pulmonary complications. Most of the papers looked at in this included some kind of inspiratory muscle training. So therefore it makes sense that they've found that inspiratory muscle training does reduce post-op complications because that's mainly the thing they've looked at. This paper looked a little bit more at the kind of post-operative period in terms of prehab will reduce your post-op readmission rates. More about ICU readmission than hospital readmission, but overall it does reduce readmission rates. It significantly lowers post-op complications, pulmonary complications. They then looked at a subgroup analysis that looked at whether you were doing prehab versus control in patients who were having neoadjuvant then surgery or going straight to surgery alone. And they found that generally, well, everyone with prehab did better. I don't know why I have to keep going on about this. Prehab's good. If you're having neoadjuvant therapy before surgery, prehab is better. If you have esophageal cancer over gastric cancer, you do better with prehab. If you have exercise, nutrition and psychological support, the 3 pillars mentioned by Sonia earlier, And none of these papers have looked at anemia, optimization, frailty. So, yeah, sorry, not going to solve your frailty problem. The 3 together are better than any combination of them less than 3. So what have we done locally? Since 2018, Macmillan had funded a physiotherapy-led physical activity project based at Beats in West of Scotland Cancer Centre, which is the regional centre for cancer treatment in the west of Scotland. It delivered a blended one-to-one online because of that pandemic that we all remember, or don't remember if we've chosen not to. A mixture of one-to-one and class supervised hospital-based exercise classes. It saw 491 patients up to 2021, and then there was a change of staff, and it saw upper GI cancer patients till 2023. Unfortunately, it then ceased seeing upper GI cancer patients. The reason given for that was because they were trying very hard to get nutritional support, and they didn't believe that physical activity, which is supported by the evidence, that physical activity on its own does upper GI cancer patients the same benefit if you include nutrition. What it does show is it shows the same things that the evidence shows. People are physical, their physical health is better, their quality of life is better, their length of stay is reduced. Interestingly, this looks at the cost, this is unpublished. This looks at the cost for the prehab group versus the control group. There's like 20 patients and 13 patients in each group, so it's very small numbers. But the patients who had prehab spent longer in ICU and cost more in ICU, obviously, if you stay longer. But the patients in the control group were in hospital for longer overall. There's a couple of outliers there, so the data's kind of skewed a little bit. What it did show as well is that patients who have prehab have less post-operative healthcare contact, and that includes outpatients and ED attendance. And it is cost saving. It showed it saved about £3,500 for this patient group per year, which doesn't sound that much, but if you could apply that across all of the groups that you could do prehab in, and if you look at this idea of the incremental QALY, or the cost utilisation ratio, then the idea is that NICE have set this standard that if something saves £20,000 to £30,000, then it is worth investing in, and prehab very definitely saves more than that. But why are we seeing a difference? So as mentioned before, Glasgow has quite a high rate of deprivation, and what we know from work that was also done in this group is that people who are in more deprived areas are less likely to take up prehab and are more likely to have healthcare contact. We also know that the patients who are more likely to take up prehab are higher risk, so therefore are more likely to go to intensive care. So that idea that they stay in intensive care for longer and it costs more is maybe not as valuable a point as we should really think it is. What do we know about cancer and deprivation? I'm sure I'm telling how to suck an egg here, but cancer is more common in the most deprived areas, and so is the mortality. I don't know how many of you have seen this idea, but in Glasgow we have the Clockwork Orange, and each stop, so there's a very difference between the least deprived areas and their life expectancy and the most deprived areas with their life expectancy. And the further you go into each of those areas, the bigger stepwise change you see in life expectancy. It's less pronounced for women, but it still exists. Cancer isn't any different. If you lived in a more deprived area, you are more likely to have a poorer outcome with cancer, and you're less likely to live as long as those who live in a more affluent area. English is failing me today. So why does inequity and injustice affect people's engagement with prehab? This isn't that well studied. So we have to kind of infer what we think causes these problems from other research about health inequalities and engagement with healthcare services. But just think about this. If you're a person who is in full-time employment in a job like ours that has got protected sick leave, you've benefited from a higher education, you have got the benefit of the understanding of the influence that you have on your own healthcare outcome. You are probably more likely to take up the offer when somebody says to you, doing this will do you benefit and you'll do better with treatment, because you're more likely to be able to understand it. And as Sonia said, certainly in Glasgow, we have a relatively low health literacy level. So if you're a person who hasn't been able to complete full-time education, or who has struggled with education for any reason, who is now working more than one job to make ends meet, who because of that has to live in an area where there is more deprivation, you're probably more likely to be a full-time unpaid carer. The burden of appointments just to go for your cancer treatment is probably going to stretch your budget beyond what you can afford. So if somebody then says to you, oh, by the way, you also need to come along to this on a separate time, you're just going to be like, no, I can't afford that. That's 3 bus journeys that I just can't do. So how has that changed our focus in the west of Scotland? So we're now focusing more on how we move prehab out of the hospital and into the community. For the past 2 years, I would say, we've spent money on having prehab advocates across the west of Scotland who have developed service maps of what's available in the community to support patients with prehab, to try and make sure that there is a more equitable offer for prehab across the west of Scotland. Our Maggie's centres deliver a 90-minute universal getting ready for treatment workshop, but one of our health boards in the west of Scotland doesn't have a Maggie's centre, so the patients were having to come up to Glasgow for that. That service is now delivered in that health board. As Sonia mentioned, we've also employed a prehab assistant practitioner, specifically with the aim of understanding what prehab needs exist in our population and delivering prehab. There's a national website, scan the QR code if you want to see it, that has been developed by Scottish Government-led work that's all about patient education and staff resources for prehab. But mainly, I'm very persistent and annoying, and I constantly go on about prehab, and I'm constantly looking for more money for it. It does feel a bit like the inaccessible pinnacle, but people can climb the in-pin, so we will get there, and I'm more than happy to be contacted. Thank you very much.
Thanks, Myra. Well, I'm just going to invite all the speakers from this morning just up to the stage just for 5 minutes. I know we're running slightly behind, but just if there's any questions for any of our speakers from the talks this morning.
Stand in silence.
Stand in silence.
Everyone's entering High Rocks.
So I just want to say to the panel, like, should we as surgeons learn to say no more often, or do you think there's always, because the hope is always we can optimise, we give it time, or should someone just be sensible and say no at the start? Sorry, that's a question to all of you.
I think Sonia and I will probably say the same thing, but yes. I think there are patients, there's certainly patients that we see that from the outset you can think it doesn't really matter how much better we get them. You're never going to give them the quality of life that they want, and they're just going to die in pain and regret having their treatment. So I think yes, but I don't think you can universally define what that patient is.
I was going to agree and say, I think accept that shared decision making and making decisions is a skill. And, you know, we admire the skills that you as a profession have. All those hours you spend in theatre, refining dexterity and everything else, well, they're hours I've spent making decisions and dealing with complexity. And I think that was the point I was trying to make, in that we have to accept we've all got a different part to play in the same journey together. So it's decided on that individual basis who's the right person for that specific scenario. Sometimes it's you, sometimes it's not, but it's a skill. Talking to a human being has a number needed to treat of one, but has a number needed to harm of one as well. It's very powerful, but only in the right lips.
Question over.
Hi there, this is Mark Johnson. So I'm Kat, I'm one of the AMPs in Aberdeen. So we're currently doing a big prehab project at the moment, of your issues that you came across with setting up the service with the geriatricians and the anaesthetists and the team for prehab?
There's lots of barriers, but there's lots of enablers. We did the approach that you've done. We started inpatient, and that was mainly for the reason that I believe you've got to have credibility in this field. And, you know, I can't come up to a surgeon or an anaesthetist and say, I think X, Y, or Z, because the reasonable reaction to that comment is, who the hell are you? So we thought it was all about building relationships, which it sounds like that's the stage of evolution you're at. You also have to leverage these people to get into leadership positions. So I was our clinical director for 5 years around the time that we evolved the service. Now, obviously, I was fair as a clinical director, but you're obviously going to start to push your vision for geriatric medicine going forward. Money speaks volumes, but the danger with geriatric medicine at the moment is it's a busy portfolio of work. We're effectively in every single economy you can think of, apart from paediatric care. That's both a good thing and it's a bad thing because it can become distracting. So as I said before, managing egos and also just helping empower those leaders that are doing it and give them feedback as well. But I do think Neela is one of the best motivators that will help kickstart it. But anything we can do to help you locally, just give me an email and I'm more than happy to help.
Thanks very much. We'll draw that session to a close. Thanks to our speakers.
Thank you.